Okay. Aaron, thanks very much for setting up this interested parties meeting for the subcommittee of the medical board involved in um, trying to organize the opioid prescribing guidelines for the medical board and its recommendations. And we are very happy to have everyone here today. It's really a critical thing that we have as many interested parties available today to help us reframe the opioid prescribing guidelines. And we're very enthusiastic about it. We're very excited about the potential for actually doing something that would really help patients and to also help our clinicians throughout the state to be able to um, have a safer and more clear way of addressing opioid prescribing. As you all know, opioid prescribing has been a major button issue for several years, uh, to to some degree associated with the volume of opioids being prescribed, but also to some degree associated with the number of opioid overdose deaths that has been recorded in the state. And of course, every death is tragic, and we certainly, um, as the Medical Board of California, our concern primarily is patient safety. Um, and part of that patient safety is being able to prescribe for those patients that critically need these medications a safe and viable environment for that to happen. Um, so I would just like to say a couple of comments here at the beginning, just to kind of set the stage. Early in at the board meeting in January of 2021, the medical board discussed this issue of the opioid prescribing guidelines, recognizing that a number of things had changed in the environment, um, and felt the need um, to initiate a task force to review the opioid guidelines and to try to update and optimize the Medical Board of California's guidelines. Um, yeah, both there are a couple of reasons for this. Number one, there have been some updates on a number of levels, and people can argue whether or not these are appropriate, but the CDC and FDA had certainly had thoughts on updating their guidelines. Um, Unfortunately, many agencies, health plans, other kinds of oversight agencies took the guidelines as very strict guidelines and didn't see them as kind of um, as guidelines. And as a result, a number of people who were on larger doses of opioid medications for chronic conditions that were intractable were significantly disadvantaged, and and maybe that's an extreme understatement. Many of them were really harmed by rapid tapering off of medications, and and what happened in the environment was that many physicians, many primary care physicians in particular, on which this burden had fallen, basically backed out of the um, arena in prescribing chronic narcotics, and it became so either litigious or regulatory oversight was in in part. Uh, Admittedly, the medical board itself had oversight in these areas, and we had initiated a number of projects in good faith, but recognize now, as we look back at it, some of them may um, have not helped overall patient safety, but actually had contributed to some patient harm. So, as you look over the guidelines today, I think you'll see a change in the tenor and the overall tone of the guidelines. We are recognizing the very complex arena we're dealing with, from acute postoperative pain or acute post-traumatic pain to chronic refractory pain from um, increasingly common conditions like um, adhesive arachnoiditis and um, uh, chronic severe peripheral neuropathies and other types of reflex sympathetic dystrophy type pain. These kinds of pain are very difficult to manage and frequently create a whole different arena. So the subcommittee on the medical board, and I want to just say great big thank you to Ryan Brooks, my other medical board partner on this project, for his leadership and his thoughtfulness, but also to our subject matter experts that we've consulted throughout this process that have been extremely helpful in helping us create, I believe, a tone of increasing recognition of the need to individually manage people with chronic pain in particular, to try to minimize the use of narcotics initially for acute pain, but when it is necessary, that we use a variety of modalities, including chronic opioid therapy, to help people with severe chronic pain to be able to maintain their functionality and maintain their quality of life. I think the tone of the document, at least our intent, was to create a document that had flexibility built into it, but also to create some guardrails that if physicians were to follow these guardrails, they would find it safe to prescribe opioid therapy without feeling like they were going to be micromanaged to death by the medical board in particular. And so I think that sets kind of the overall tone for this. And I want to just also say I really appreciate the public comment. I think there's been really thoughtful and articulate commentary given to the subcommittee from the public. Many of them patients who have been adversely affected tragically, and many of them who are advocates for their spouse or a relative who've had difficulty. And we want to just say thank you to them because they have provided a real insight that is really important as we go forward with this project. So once we've obtained public feedback and comments have been obtained, we're going to review the draft guidelines again and update them as necessary in response to the concerns expressed. There have been some concerns, and we'll talk about them, about urine drug testing and morphine equivalent dosing, or maximum morphine equivalent dosing, those kinds of things. There may be, we may not be able to completely eliminate those things, but certainly we want to give the physicians and other clinicians that are prescribing these medications guides to being able to do it in a safe way, and in a way that is patient friendly, and still provide non-judgmental care for patients that require these difficult these medications, but many of these difficult problems that patients face are extremely complex and difficult to manage. So I think with that, I will just turn it over to Mr. Prasivka for moving on to item number 2.
Thank you, Dr. Thorpe, and thank you to Dr. Thorpe and to Mr. Brooks for their leadership on the task force and giving the executive direction to bring the project through to the stage that we are currently. Just a little bit about item number 2, which is a summary of the process, which was used to update the guidelines. As Dr. Thorpe has mentioned, early in 2021, the board did make a decision that the guidelines should be updated. These are the 2014 guidelines. And obviously there was a view that there was a lot that had happened since 2014. The issue of prescribing, the issue of controlled substances was very much at the heart of the work of the medical board. So it was a very appropriate use of our resources at this point in time to move forward with updating the guidelines. As Dr. Thorpe has mentioned, we recruited subject matter experts to go through various parts of the guidelines. The executive did a review of everything that had happened legislatively and from a regulatory point of view since the 2014 guidelines. There had been a lot of changes in regulation and in legislation. We looked at other jurisdictions to see what they had been doing in their intervening period. Subject matter experts were retained, and we therefore proceeded to come up with a draft set of guidelines. First draft was completed earlier this year. Again, the task force met. The executive then worked with subject matter experts to ensure consistency throughout the draft and to bring it to the point that it is currently. During this entire process, the CDC itself was updating their own 2016 guidelines, and they issued their document in mid-February of this year. Staff analyzed this to ensure that we were taking any changes that were necessary into account. The draft guidelines have been distributed to medical societies, the Society of Addiction Medicine, California Primary Care Association, academic pain management departments, and consumer groups to solicit feedback and input. Just from a very high level point of view, there have been a number of overall high level changes in tone and philosophy, as Dr. Thorpe has already alluded to. We have an addendum to the materials setting out some of the major changes that have taken place from the 2014 guidelines to what our update draft includes. Some of the main changes include eliminating references to MME dosage limitations and prescribing and instructions related to the use of extended release versus long-acting opioids, and the statutory requirements to consult with Cures database and to offer prior to prescribing patients who meet specific criteria have also been added. Moving on to agenda item 3, the overview of written comments received. Again, just to reiterate the point made, we are very grateful for the comments. Many of them obviously took a great deal of work, and so we are, again, very grateful, and all of that will be carefully considered. Public input is being solicited to help identify issues in the draft guidelines which could unintentionally impact either a patient's access or a physician's ability to provide appropriate medical treatment. The written comments we have received have been posted to the board's website. Respondents express the difficulties they have experienced as a patient getting effective treatment and concerns about how previous guidelines were interpreted as a way to impose prescribing limits. There were several overlapping comments, which I would like to briefly summarize. Several individuals suggested adding definitions for palliative and hospice care to understanding pain terminology section. The section titled Morphine Equivalent Dose received the most comments from patients and physicians. This was not surprising. Physicians expressed concern about the accuracy of the tools used to calculate MMEs, and patients were concerned that any reference to opioid doses over 50 or 90 MMEs could be interpreted as a prescribing limitation. We do intend to address these issues further before finalizing the guidelines. Comments were received about the compliance monitoring section, particularly urine drug testing and pill counting segments. Patients expressed the concern that the use of these strategies could be destructive to the doctor-patient relationship by implying that the patient was not trustworthy. Urine drug testing can be expensive for the patient and can produce false positive results, which can be detrimental to patient care and used as a justification to terminate the patient. Finally, the section on discontinuing opioid therapy received a number of comments, including concern that there was more emphasis on discontinuing treatment than ensuring patients achieved good pain control. The recommendation that a patient received a minimum of 30 days advance notice before being terminated was identified as inadequate given the shortage of pain management physicians available to accept new patients. I can assure you that all of these comments will receive very careful consideration by the executive, the task force, and our own subject matter experts. Now going on to agenda item 4, which is open discussion of the draft guidelines. Again, we are very grateful for the comments received. We welcome all the attendees. I note the large number of attendees. We've got now basically 1 3/4 hour to attempt to get through this as much as possible. I would ask all the people who participate to, again, try to use their time as effectively as possible. We have received your written comments. There's no need to simply repeat them in their totality. We welcome your comments to highlight ones you previously made or new ones that you would like to make. We would like the comments to be focused on our draft guidelines. That's what we're here today. There's lots happening in other parts of the world, other guidelines that are very important, but we'd like to focus on what we can do, on what we can control, and how we can make these particular guidelines as effective as possible. So having said that, I would like to turn it over to Sean to invite public comment.
Thank you very much. For those wishing to make a public comment, we've activated the hand raising feature in the Q&A feature of WebEx. So you should see down at the bottom of your screen a little hand icon or a Q&A button that if you click that Q&A button, it'll open up another little window. No need to type the question that you want to ask. Just say, I'd like to make a public comment, or type anything in there. We'll call on you in the orders as the requests come in. We're going to go with approximately a 5-minute time limit to start off here. As Mr. Pacifica mentioned, there's quite a few people in here, we're guessing, that need to make public comments, so we might have to shorten that at time. But please just be thoughtful that any additional time that you're taking up might cause less people to be able to speak. So up first here we have Kristen Ogden. Kristen, I've gone ahead and sent the request to you, and those of you wishing to make a public comment as well, when I do call your name, we'll send a request to you, and you actually have to click a button on your end to open up that line as well. So Kristen Ogden, please go ahead.
Can you hear me?
We can.
Thank you for the opportunity to comment today. My name is Kristen Ogden, and I speak today on behalf of Families for Intractable Pain Relief. Most of our members are former patients of Dr. Forrest Tennant or family members of those patients, and we really do thank you for the opportunity to comment. We really believe the draft guideline document includes some desirable changes and a somewhat more positive tone. However, we find also that it continues to reflect the pervasive bias that we find just about everywhere against the use of opioid pain medication in some places. There's always seems to be an underlying assumption that our opioids are bad. Risk versus benefit is often mentioned, but potential benefits receive very little attention in the draft. It's kind of like a form of subliminal messaging, not specifically stated, but the message is clearly negative. Please understand, I mean no disrespect to the authors of the draft, but this kind of messaging is one of the major barriers that affects pain patients. The patients we represent have very severe, constant, intractable pain, usually with life-threatening cardiovascular, endocrine, and neurological complications, a set of predictable consequences that may be accurately described as intractable pain syndrome. Many of these patients require unusually high dosages of opioids to achieve pain relief, and if adequately treated, experience good pain relief, reduction in complications, improvement in function, and reduction in their underlying illnesses. It's estimated that the subgroup of patients make up a very small percentage of chronic pain patients. Yet we often hear the same message. NSAIDs are good. Despite the potential for serious side effects, opioids are bad, even when they allowed these patients with constant severe intractable pain, for whom all else has failed, to more fully engage, to be active, to go places and do things. In other words, to have a much better life. This pervasive negative tone that opioids are bad is one factor that we believe drives the stigma against chronic pain patients. For example, I'll just briefly say the paragraph about physical dependence illustrates kind of what I'm saying. It acknowledges that dependence is not the same as addiction. It goes on to talk about withdrawal symptoms that may be minor or severe and that they can be managed by medication or slow tapers. However, it could just as well be said that dependence is a predictable phenomenon that is not in and of itself necessarily harmful. What about diabetics dependent on insulin? Persons with cardiovascular issues may be dependent on blood pressure medicines. The tone just seems to generally be negative about opioids, rarely if ever neutral, even though opioids mean the difference between having a life worth living and having a couch-bound excruciating existence. The need to observe and measure functional improvement is also a recurring theme in discussions about opioid treatment for pain. And in the words of Judge Peter J. Wilson, November 1st, 2021, Superior Court of California, County of Orange, the court is persuaded, based on the evidence in this trial, that effective pain management and improved or improvements in function are closely linked concepts. It seems beyond debate that for a patient whose pain has been sufficiently controlled, that they are able to resume some of the basic functions of life, shopping, cooking, cleaning, and so on, that patient's function has improved. We're disappointed to see the continuing focus on MME. We addressed our concern in our written input. We do not believe that physicians who have left the practice of pain care will be enticed to return to treating pain patients if the final guidelines include so much focus on MME numbers. They will continue to be weaponized against physicians, and patients will be left without care. We believe that if you really want physicians to come back to pain care, it would be better to delete MME from the guidelines. In 2019, the FDA said, unlike other approved analgesic products, most opioid analgesics have no maximum dose because there is no ceiling effect for analgesia. Further, along the range of doses that have been used clinically, no particular dose of any opioid has been determined to be a cutoff point between safe for use or unsafe for use. The patients our group represents are generally not acknowledged, nor are their medication needs acknowledged.
1 minute remaining.
They are not addicts. They are legitimate patients with extraordinary pain conditions and extraordinary medication requirements. They must be acknowledged as such so that they can receive the treatment they need. If, however, you are unable to make room for them in the new guideline, we urge you to seriously consider pursuing a special program, a carve-out that would enable care for them, protect these patients, the physicians who care for them, and the pharmacists who dispense their medications. In conclusion, I refer you back to our written inputs. Also, I state for the record that I fully support and agree with the positions of Dr. Richard Lawhern and others on the use of MME, and that physician overprescribing did not cause the rise in opioid overdoses. Thank you very, very much for the opportunity to comment.
Thank you for your public comment. I neglected to mention as well too, thank you to the Q&A person who typed in. If you called in for audio, but you're also connected via computer, then raising your hand on your computer will do the same thing as raising your hand here. But if you called in only on a phone, I do see some call-in only users. You can press *3 to raise your hand via your phone, like if you're not connected via a computer at all. And that will put you into my view as raising your hand, and then you'll be prompted when we call on you to press *6 to unmute at that time. So anyone wishing to public comment that's not connected by a computer, I will have to call on you only then by your by your phone number, the area code and the first 3 digits. So let's see, next up here we have Scott Guess. Scott, give me a moment to send you that request. You should be seeing it on your end.
Now.
Go ahead, Scott. We can hear you now. Thank you.
Fantastic. First of all, I want to thank the members of the board for the opportunity for stakeholders to speak today about the new prescribing guidelines. I'm speaking to you as a pharmacist who has been in the pain management field as both a mid-level provider and a dispensing retail pharmacist for nearly 30 years, maybe a little bit more than that. Additionally, I am a pharmacist with a master's degree in pharmaceutical outcomes policy and a master's degree in palliative care and a diplomate of the American Academy of Pain Management when they existed. So I do have some knowledge of the field of which I speak. Really was impressed with the 2014 guidelines. And the thing that struck me most about that, And what got the most attention by the pain management community was the fact that you decided to go with a definition of pathology-based dichotomy, separating pain into neuropathic and somatic, rather than using the old standby of cancer and non-cancer pain. Sadly, as I read the new guideline, it appears that we've returned back to the cancer, non-cancer pain. And I would like to remind the members of the board and the authors of the guidelines that pain and how we treat it is based on the pathology and not by the diagnosis. By the physiology and not by the diagnosis. And there are a lot of people who have post-traumatic pain, who have genetic diseases like sickle cell, Ehlers-Danlos, people who have mechanical issues, scoliosis, kyphoscoliosis, adhesive arachnoiditis. We have genetic or neuropathic conditions such as RSD, and they're treated differently, but they're not necessarily separated by cancer, non-cancer. They're somatic versus neuropathic. I would like to see that definition brought back into these new guidelines. The second point that I would like to, oh, by the way, and much of the guideline is absolutely beautifully written. I love everything you had to say about it. There are a few things that could use maybe some tweaks, but I know a lot of people have addressed that already. The second point that I really want to make about that is the section called Supervising Allied Health Professionals. And you spoke specifically about nurse practitioners and physician assistants. They are not the only licensed category of allied health professionals. I hold Advanced Practice Pharmacist License number 43 issued in this state by the California Board of Pharmacy, issued in authority or by authority of Business and Professions 4052.6. Since your guideline is going to include a section on supervising allied professionals, please be sure to include the advanced practice pharmacists in that section. There are 300 of us at my last count or more, and some of us do work in the pain management field. They can't be neglected. We're out there, and the board has made that possible for us. The other thing I want to address is in several places the guideline speaks of primary care physicians. I feel the board should also include a section for pain management and allied provider specialists, pain management specialists, the docs who care for the legacy patients, the high dose patients, the most challenging, the worst of the patients. Those who are so bad off that they reside in that third standard deviation from the mean on the bell curve of people who take pain medications and how much they need. Those whose morphine equivalents are not measured in milligrams, but measured in grams. And don't kid yourself, you and I both know that those patients exist. Many are high-functioning working folks. They're employees, they're self-employed, they're employers, they participate in family events and life in general at what some people call horrendously high doses, but it's what they need to function. The physician I worked for as an allied provider had over 100 patients that fit this category. Not a single patient of his experienced an overdose death. He had a very strict protocol, and it looks a lot like what this new guideline does. The last thing I want to address, and I understand the board was interested in the barriers to patients that patients are encountering to preventing access to legally prescribed opioids. And I see three root causes. One of them was, and I think Dr. Thorpe alluded to this earlier, was the medical board's death certificate project. This project had a very chilling effect on prescribers whose livelihoods were put in jeopardy when a person who died, and I always tell people that birth is a terminal diagnosis, had ever been prescribed an opioid. Message received, don't prescribe opioids. The California Board of Pharmacy, they're not doing much better. When their inspectors show up to pharmacies and demand written justification for why a patient might be more than 5 miles, or the patient might drive more than 5 miles to their pharmacy from either their work, their home, or their physician.
Please conclude.
And other factors that were addressed and other factors not addressed by the triad of legitimate medical use by an individual prescriber prescribing within the scope of his practice. By the way, this 5 mile radius is not codified. It was a random number chosen for who knows reason. And then finally, and I'm sure this one's going to get me a little bit of trouble.
Scott, you've exceeded your 5-minute time limit. Could you please conclude?
I got just the Drug Enforcement Administration DEA has reduced opioid production limits up to 75%. People can't get medications. DEA, through citations and litigations and MOAs, have limited what wholesalers can dispense to pharmacies. We can't get medication even if we wanted to. And then DEA investigations. And
Thank you, Scott. I'm sorry, you're a minute over your time limit. If you have additional comments, you can go ahead and submit those via writing. Next up, we have Rosie Arthur's-daughter. And I'll continue to give everyone a minute notice when you're 4 minutes into your 5-minute time limit. We just want to be sure that we can get everybody to make a public comment today during today's meeting. Rosie Arthur's-daughter, you should be receiving that prompt on your end.
Hello?
Yes, Rosie, we can hear you. Please go ahead.
Okay. Thank you very much for this opportunity, and I appreciate your remarks in the beginning, Dr. Thorpe. As you know, I've been attending these meetings for a long time, and on specifically the prescribing of controlled substances for more than 10 years. And this problem goes back even longer. And as a researcher, as a healthcare professional, as a person who's been in forensic fields for a number of years, you know, what we have here is like our untended force. We're trying to clean up one area, and we have, you know, many, many more acres that are left untended, and other fires will sprout up, even though we've cleared one area. And the basis of these, through no fault of any of the folks here at the medical board, came from a special interest group that is the insurers in workers' comp and the defense in workers' comp, who had a particular agenda for the ultimate risk limitations and providing care to patients. And then their guidelines were adopted by the board in 2014 over the objections of patients, etc., and many of the doctors. So when you talk about root causes of everything that's sprung from that, that's where it is. The guidelines are still lacking a direct link to the law like it used to have for intractable pain, or specifically showing the providers, the doctors or any of the other providers, where they are allowed to treat these patients. And so without that in there, where it used to be in there, everybody thinks it's gone. And it's very important that that be restored. Now, I've been working on another project, so I wasn't able to prepare written comments. I will do that afterwards, and I will integrate what's already gone through and what happens here, because I did see some glaring omissions. One of the things is you were talking about definitions. Absolutely. I think you need to have something in the way of clinical pearls and best practices that explains these clinical terms of art that may not have existed when a particular physician or provider went to medical school. Or if they've gotten their training provided by some MAT corporation to get them to push MAT therapy, then they are biased against all the other options. For the most part, there aren't pain managers out there who actually treat pain. They treat a number of other things, and they are not open to new patients at all. For the obvious reasons, the death certificate project. So yes, definitely a chill, and it has killed people. My son is one of those people that, because they said, oh, you don't need your pain medicine that you've taken for 24 years successfully. We are going to give you Prozac because you're depressed about it, which he couldn't metabolize and eventually brought his death. So, 24 years of successful treatment, being able to hold his family together, have a job,
1 minute remaining.
community. Okay, so these things are gone. So you need to define these terms. You need to do testing for anybody who's given pain management medications or psychiatric medications. They need to be tested for metabolism. That is CYP450, the various different enzymes, because that will be the key to what you can and can't prescribe and what you can mix and what you can't mix. That needs to be there. Okay, and that's something that maybe the gentleman who's a pharmacist might help with something like that, because when you go to see your pharmacist, they should be able to say, oh, gee, you're taking too many medications that are metabolized this way. Are you having any problems? Or bring it to the doctor's attention. So this is an area that is perhaps more responsible for our problems with medications than anything else. And I'm not just saying controlled substances, because your pain medication can also impact how
5 minutes
effective
has elapsed. Please conclude.
or ineffective your heart medication is. Anyway, so I will put all these things in writing again, and hopefully somebody will take some of these things to heart, because I don't want to see anybody else die needlessly like my son died. Thank you.
Thank you for your public comment. Up next, we have Anne Fuqua, and send that request your way.
You hear me?
We can, Anne. Please go ahead.
Okay, great. My name is Anne Clay. I am part of Families for Intractable Pain Relief. I want to echo what the previous speakers have said. As one thing from as Dr. Cass had said about the use of somatic pain and neuropathic pain versus cancer and non-cancer pain. I think that's very important, because we have this sense that cancer pain is worse. Cancer pain is more deserving of treatment than other types of pain, and it's the fact. And I think that's one thing that that probably from the 2014 guidelines you probably should revert to revert to that terminology. And then beyond that, I have tried to shorten what I was going to say, because Kristen did such a good job explaining our position. Would be that patients with that are the highest dose patients, like myself, getting physicians to treat us. I think it's going to take having as she said, I think they're still going to be reluctant and afraid to do that. And, I think it needs to be more, or as more, the, if you, to be able to say, if, excuse me, if they can, they're gonna, physicians, and other, are gonna need more, more reassurance that yes, if I treat this patient, this way, and they need, and that I'm gonna, stay in the, protect my, protect my life. They need to, as the, I'm so, I lost my page where my comments were written, but if you can, uh, if reassured that, that what they're doing, it was within the guidelines. And as Kristen said, there's so much talk about the risk of opioids, and less about the benefits, and other medications, NSAIDs, those Tylenol, those have very real and very real risks as well. I think that physicians, when they're looking at when they're saying documenting the risks and benefits of medication, providing if it I'm so sorry, but if they can, if there's more explanation about what exactly benefits, I, I'm so sorry. Oh, shoot. the just as far as giving them the guidance about specific, as patients have that they're that they are benefiting, like as Kristen said, there's
And it sounds like you walked away
uh,
from your device. We're having
I'm
a
so
hard
sorry.
time hearing you.
I'm so sorry. I've got that, and I've got an echo in the background. Kristen really has said everything that I wanted to say, and Dr. Guess and Ms. Author's daughter too. And I'm so sorry. I'm trying to talk with it, and I've got an echo in the background, and it's making it really difficult. So thank you so much.
Okay, thank you for your public comment, Ann. Up next here we have Aaron Rowland. Aaron, you should be receiving that prompt on your end.
I am a family physician with 30 years of private practice in Burlingame, California. I'm also a clinical professor of family medicine at UCSF. We treat pain patients in our office, and those pain patients are not referred to us. They just arise out of our practice. But given that about 30% of our practice is Medi-Cal patients, people who are poor and disabled. There's a fair number among that population, as well as among our commercially insured and Medicare patients. We've, you know, we pride ourselves in our practice as being one of the highest quality practices in the peninsula. We see on average a clinician will see maybe a maximum of 12 patients in a day. So we take our time with our patients. We're detail oriented. We're very, very close and in close contact with our patients. Um, uh, Unfortunately, one of our clinicians recently had to leave our practice, because she had to devote herself full time to defending herself against a case brought by the Medical Board of California for opiate prescribing. Um, I'm not going to go through the details of the cases here, it would be inappropriate, but I will mention that one patient who was managed effectively for well over a decade in our practice was ultimately discharged from our practice because of drug findings of cocaine in her system a couple of times. And this led to her ultimately finding drugs on the street. And this is one of the tragedies of this effort to this demonization of opiate use, and this strict looking at every little thing and making.
Dr. Rowland,
Yes,
do
ma'am.
you have comments on the
Yes.
draft of the prescribing guidelines? I just want to make sure we use your time effectively.
I do have comments, but this is a prelude. The comments that I have is I think that there needs to be something addressed in the documents about the nature of what oversight involves, and oversight when enforcement actions are appropriate. I think there should be some effort in the document to making sure that there is addresses the shortage of pain consultants. We have found it impossible to find pain consultants. There is nobody to refer our pain patients to, particularly to patients who are on public programs. There is nobody who in our community who will manage chronic medical pain. In addition to which, in looking over the guidelines and what's advised and has been advised in the past for what primary care management of pain patients involves, there's very little recognition of the workload that involves. Seeing a pain patient every 3 months and doing a comprehensive pain assessment and evaluation is an extremely big workload, particularly for those patients who have a clear explanation for pain. They may be stable on pain medication for a long period of time. There needs to be recognition of the finesse, the differences between management of different types of patients. And I really think that there's been too much effort, even in these guidelines, which are far improved for some of the stuff that enforcement
1
actions
minute remains.
are coming from. That there's too much emphasis on putting people into the same boxes. I'll stop there.
Thank you for your public comment. Next here we have Radine Marie Cook. Radine, let me go ahead and send you.
Sean, this is Dr. Thorpe.
Go.
I would just encourage Dr. Rowland to write out his comments and submit his comments in a written fashion so that we get the opportunity to actually get his expertise in a because I feel like he has more to say, and I think his expertise is appropriate, is very helpful, and if he'd be willing to, it would be helpful, I think, to get his comments written to submit to the subcommittee.
Absolutely. Next up here we have Radine Marie Cook. Radine, your line should be open. Radine, looks like your line's open, but we're not hearing any audio from your end. So if you a secondary mute button or something like that, you might have to look into that. Otherwise, I encourage you to go up in the audio and video options on the WebEx application there, and you can select switch audio and call in and do it from a phone line, and that way we can hear your public comment. I'll go ahead and mute your line at this time and lower your hand, but if you can call back in via phone, please go ahead and raise your hand again. Or it looks like maybe we lost you altogether. Next up here we have, Francis Monty Goddard. Francis, you should be receiving that prompt on your end.
I can. Can you hear me?
We can. Yeah, please go ahead.
Excellent. Excellent. Hey, mine's only going to be just over 2 minutes because that's what I thought we were restricted to. I got to say, I go by Monty Goddard. My given name is Francis Goddard. My wife and I are lifetime residents of California. I'm a licensed civil engineer. Thank you for this opportunity to speak today. My written comment with specifics is included in this meeting's agenda materials. I appreciate the positive action taken to update California's prescribing guidelines. I find the draft encouraging, as I did the comments of Dr. Thorpe and then board member Dr. Kraus at your April 11th, 2021 stakeholder workshop when they responded to Kristen Ogden's excellent public comment. I endorse the submitted comments of Dr. Red Lawhern, Rhonda Favero, Rebecca McCaslin, and Kristen Ogden. My loving wife's life, and I'll add somewhat selfishly, that of my own, have been ruined by our government's mistargeted war on the so-called opioid epidemic and the CDC's opioid prescribing guidelines, with their, as Dr. Red Lawhern is fond of saying, junk science-based MME medication recommendations. Now in our early 70s, we have lost forever much of our golden years, years we will never get back. Our mutual loss and my wife's unnecessary inhumane suffering are the direct result of the CDC's junk science MME recommendations. Despite warnings, classifications, and alerts from the AMA, the FDA, the CDC, and on more than one occasion, California's Department of Public Health, these MME recommendations are de facto upper prescribing limits. Truth is, physicians who exceed these recommendations, especially if they have several complex pain patients warranting higher MME prescribing, are at professional and personal risk. I recognize the out-of-control DEA, despite the Supreme Court the recent Supreme Court Ruan case decision, still hold the sword of Damocles over physicians. They're the ones that give the physicians the right to write a prescription for controlled substances. Despite this sad fact, I implore you to please do what is in your power to mitigate this tragedy in some small way. Conclude this draft's document, page 9, morphine equivalent dose paragraph, by explicitly stating California physicians are not subject to the CDC guidelines MME recommendations. Thank you.
Thank you for your public comment. Up next here we have Virginia. Virginia, you should be receiving that prompt on your side there.
And as Virginia is coming on board, I just want to remind people, if you could please direct your comments to any recommended changes to the draft prescribing guidelines. That will help to make sure that it's focused on improving this draft, and also make sure that we get to hear from all the speakers who are interested in speaking today. Thank you.
Thank you, Carrie. Virginia, you're there? Virginia, your line's open. If you saw you come off mute, so if you have a secondary mute on your device or anything like that. Okay, Virginia, raise your hand again if you can get that worked out. Next up here we have Alicia Sanchez. You should be receiving that prompt on your end. Alicia?
Can you hear me?
Yes, we can. Please go ahead.
Alicia Sanchez with the California Medical Association. Thank you so much for the opportunity for everyone to come together and have this discussion today, and for all of the work that's been happening prior to today. We really appreciate the recognition in the preamble about the history of the work that's been done, including what has happened in post the 2016 CDC guidelines, and want to align with other comments that suggest the morphine equivalent dose section should be revised to remove specific MME dosage limits because they may be interpreted as upper dose limits. And really the goal, I think, that everyone collectively shares is to have patient care be individualized and based on the patient's needs, and would want to avoid that. Additionally, I think, and I know that the board does not seek to impede appropriate patient care, and that's definitely not the goal. But I think the board needs to be mindful of the fact that California physicians will be very pay careful attention to what their regulator produces. I think that's been referenced in previous comments as well, and that these guidelines are coming out with the history that has been discussed previously. And so we want to make sure that the draft doesn't continue to enforce the perception that there are limits and that it shouldn't be individualized patient care. The preamble does make that reference, but there are certain inconsistencies in the language throughout that make it seem as though it is more prescriptive. So one example would be the section on the morphine equivalent dose. Additionally, specific timelines for things like the evaluation after the initiation of opioid therapy and the urine drug testing. We would recommend that specific timelines that aren't statutorily defined be removed to ensure that the care can reflect the patient's individual needs. We also join with others who have raised questions about the urine drug testing. We would point out that in the CDC draft guidelines, they only urge consideration of urine drug testing as opposed to a requirement. And so consideration that be aligned, more aligned with the CDC approach or proposed approach. One of the things that we felt was not acknowledged is the impact of cost and access to care, which I think has been referenced by a few people as well. For example, there are varying degrees of coverage for things like non-pharmacologic therapies, and so treatment methodologies really need to account for all of those variances that may apply to an individual patient. And things like co-pays and cost sharing that would be associated with additional visits for things like the specific timelines referenced earlier could impede appropriate care. The last point that I would make is that the document does not speak to what has been shown over time to be disparities, ethnic disparities in appropriate pain care. And so I do think that it warrants some mention and call out in consideration. So thank you for the opportunity to provide comment, and we remain very interested in the board's work and happy to continue to work with you on this project.
Thank you for your public comment. Up next, we have an individual who has identified themselves as the Medical Board of California. You should be receiving that request on your end. There, looks like the line is open.
Hello?
Yes, we can hear you. Please go ahead.
Yes, hi. My name is Misty Hoffman, and thank you for allowing me to speak. I greatly appreciate it. Unfortunately, I don't have any pre-prepared remarks because I'm still getting over COVID, and so I'll just take it from here, from the top of my head. I suffer from high-impact intractable pain. Just a brief synopsis. I almost died when I was 20 years old. I was on life support in a medically induced coma from misdiagnosed strep throat. It caused my kidneys to quit functioning. I ended up having a stroke, grand mal seizure, temporary loss of vision, so on and so forth. Fortunately, I made it and went back to work in college a few months later, kept having issues. Eventually, when the whole right side of my body went paralyzed for a month, they finally diagnosed me with multiple sclerosis. I was told my issues were psychosomatic for several years before I got that diagnosis. Fast forward to graduating and being told if I wanted to have a family, I needed to get on it because of PCOS and multiple sclerosis. My husband and I, we had our son, and 2 weeks later, we had him via emergency C-section. 2 weeks later, I went to the doctor and told them that there was the nurse practitioner, there was something wrong with my incision. I was told it was fine. I was up all night with problems with it, and I was going to get up and have my husband take me to the emergency room. Ended up falling, crushing my vertebrae. Was told by 2 doctors to get vertebroplasty. One said no. I went with 2 against 1. Unfortunately, the
Ms.
vertebroplasty.
Hoffman,
Yes.
may I please ask you to let us know if you have recommendations for
Absolutely.
the draft guidelines?
Absolutely, I'm getting to that. That's part of my point. The fact is that the vertebroplasty was botched, leaving medical cement leaked down in my disc space and next vertebrae, essentially hardening, leaving a rock in my spine. I've tried every non-narcotic remedy possible, including spinal cord stimulator implants. My primary care physician was taking care of me, and when the CDC guidelines came out, he was afraid, so he sent me to a pain specialist. And that went okay for a couple of years until even the pain specialist became afraid to treat chronic pain and told all of the patients in the practice that everybody was being cut down to 90 MMEs or under by January 1, 2019, regardless of their individual situations. When I was upset about it, he told me, quote, "Well, you can say you're a drug addict and go to a methadone clinic." To which I replied, "No, because you know I'm not an addict and I don't want that on my medical records." And I was very unhappy. I was discharged with no cause. And so my husband contacted my primary care physician, who took me back over because I was suicidal. And my primary care physician is terrified to give me more than the 90 MME and has referred me to dozens of pain specialists. Nobody will take me. There are more and more pain specialists not wanting to work in the field. And so I believe that the guidelines really need to allow primary care providers to treat patients without the constraints of the MME guidelines. In 2015, I was on 330 MME and I functioned great. Now I'm right at the 90 and I'm bedridden 85% of the time. And I bathe once a week because it's too hard to stand and shower. I can't go watch my son's sports. I can't do anything. It took me after
1
the
minute
pain
remains.
specialist cut me. I wasn't able to get out of the bed for 45 minutes on Christmas morning to watch my son. And so there needs to be room for primary care physicians to take care of patients because there are not enough specialists, and even the specialists are running scared. And you don't know if there's a difference between cancer pain and non-cancer pain. I know some people with cancer and their pain is manageable and mild. So pain is pain, and it should be individualized care. Also, there have been scientists and doctors that have done work on the fact that the whole MME measurement is junk, because everybody has the different liver enzymes, metabolism.
5 minutes has elapsed. Please conclude.
I have had gastric bypass surgery, so oral medication doesn't work as well, and I was receiving a skin patch. Now that's gone. So basically, I believe the MME guidelines, the numbers need to be thrown out completely so doctors can treat their patients without being in fear. I will also say that
Sean.
patients.
Thank you for your public comment. Next, we have Michael Conroy. Michael, you should be receiving that prompt on your end.
The opportunity to address the board and the panel today. My name is Mike Conroy. I'm the Chief Medical Officer for Sutter Medical Group, which is here in the greater Sacramento area. We have about 300 adult primary care physicians who do or might manage patients with chronic pain. Preparatory comment, the board's pursuit of docs who haven't been completely perfect in all elements of the 2014 guidelines have basically caused I'll use the word terror because one of my doctors used this, in the minds of our primary care docs. They really don't want anything to do with any level of pain management for fear that they will lose their license and lose their job. Just to point out that when primary care doctor leaves, there are about 3,000 patients who weren't being treated for that pain who now don't have a primary care doctor, and it's having an impact for many people. Specific to the guidelines, I greatly appreciate this update. There are many things in here are much better. There are things that our doctors ask about all the time, like cannabis and like frequency of visits that are more specific, and that's helpful. So thank you. On the other hand, there are 44 mentions or uses of the word should and 7 uses of the word must in these guidelines. Now, while some of these do relate to California law, very few of these statements are backed by much in the way of hard science, although they're in some cases supported by common use in the medical community and sometimes by expert opinion. However, the use of this language can be viewed as signaling an intent to use these statements to discipline doctors who aren't perfect. And again, nobody's ever going to be perfect in documenting or attending to 51 separate things on a single visit with a chronic pain patient. So my suggestion or ask would be to consider altering the language to clarify that most of these statements are opinion and emerging science and are not intended for disciplinary purposes or are not intended to be hard requirements that will lead to discipline if they're not perfectly followed. The new guidelines do make some statements about how these are supposed to be medical guidelines, but again, the medical science and the community standard of practice is really still unsettled in many of these areas. And I would just ask the board to make it clear in its language that these are not intended for hard regulations and discipline. Thank you.
Thank you for your public comment. Just make people aware that do have their hands up. If you lower your hand and raise it again, it puts you into a queue. And so if you lower your hand and raise it again, it effectively moves you to the end of the queue. And I know we're going to be tight on time today. So if your hand's up, just please be patient and know that we will call on you in the order that your hand was raised. So up next here, we have call-in user 5. It's 916-947 area code. You should be receiving kind of a verbal prompt on your phone line there. You should be able to hit *6 in order to come off mute. Looks like it worked. Are you there? Calling user 5. Yeah, there we go. If you call in and we can hear you. If you have your phone on mute as well too, you have to turn the mute off of your phone as well. So *6 just unmutes you through WebEx. But please go ahead with your public comment.
I'm in Sacramento, California. I'm a patient. I've been going over the draft guidelines. I feel the Sutter doctor was very explicit about the burden on physicians to keep it with the medical records. They're very intense, and with treating patients, I know my own doctor spends multiple hours overtime to keep up with these medical records, even though I've been a patient for a very long time. I had a primary care doctor 3 years ago. I was going to report to the medical board because it was a mandatory refusal to cooperate with me. I have a self-designed treatment plan with all my providers, including non-medical alternative care and medicine. I've had severe scoliosis since I was a child. I see nowhere in here where there is a responsibility of the patient to provide their own treatment plan, including acupuncture or yoga or supplemental therapies. You might want to include that. I did see something in here about opioids and benzoidides. I don't know if I'm pronouncing that right. I don't use opioids. The primary care doctor I wanted to report wanted me to sign a statement about opioids, but I don't use opioids. I use barbiturates. I have since I've been 15. I did have a productive life, and now in retirement, I'm not productive. I've done many things to change society. I believe there should be something in here about patients who are able to provide a treatment program for themselves and work with their doctors. So maybe in medical records, you can include that. Also include information regarding non-opioids and street opioids. It's getting clumped together and it's getting confusing for doctors and patients. Include something for pharmacists. I had a pharmacist who was a director for a region. They did not want to fill my refill. I got into an argument, and they said they had a medical degree. They had a medical degree for pills. They did not have a medical degree for diagnosing my health condition. there's a difference there. You need to make sure that that is explicit in your guidelines. That I didn't, matter of fact, their attitude changed when I asked them why they're trying to kill me by withholding my medication and sending me into a immediate withdrawal, which would be damaging to my health. I believe patients who have been working on their pain management through different therapies need to be heard in the guidelines, maybe somewhere. My doctor did show me all the forms he needed to fill out for the California Medical Board as well as for the CDC. I was quite shocked. I'll wind it up that I was quite shocked at the amount of time you're requiring, and this is why doctors don't want to be involved in treating chronic pain. Thank you very much for listening to me.
Thank you very much for your public comment. Up next here we have, looks like Adam, I hope it's Paley. Adam, you should be receiving a request on your side.
Hear me?
We can, Adam, please go ahead.
Great, thank you. Thank you for the opportunity to comment. My name's Adam Paley. I'm a family physician in San Mateo. I'm also president of the Mills Peninsula Medical Group, an independent practice association of 240 physicians in San Mateo County, representing primary care physicians and specialists. Our board of directors and physician members have asked me to share our urgent concerns about the medical board's enforcement of policies and practices regarding opioid prescription documentation and the dire impact they're having on our patients' access to care and our independent physicians' abilities to provide pain management. Some of our physicians are under investigation for compliance with these guidelines, which are resulting in serious and I believe unintended consequences. First, our physicians specializing in pain management have stopped taking new referrals, leaving patients and their primary care physicians without local, accessible options for complex pain management. One of these physicians announced his retirement last week. Several primary care physicians have elected to retire from active practice to devote their time to defending their cases before the medical board. In our community, recruiting and retaining physicians has long been a critical issue. We're concerned that the medical board's approach to enforcement is making it even more difficult to do so. We believe that this was not the intent of the medical board. We urge you to work with the CMA and other organizations to reassess and adjust your approach to enforcement. My organization can help in any way we are available. Thank you. Thanks for the ability to comment.
Thank you for your public comment. Up next here we have Matthew Torrington. Matthew, you should be receiving that request on your end. I can hear your background audio. Matthew, are you there?
I'm here. Can you hear me?
We can. Please go ahead.
Hi, I'm Matt Torrington. I'm a family medicine doctor with a specialty in addiction medicine, and I'm the chair of the California Society of Addiction Medicine Opioid Committee. And we really appreciate all the incredibly hard work that's been done and is ongoing to try and update these guidelines. We think that this is a very, very important process, and we echo a lot of the wonderful things that have been said today. Our big picture ideas are that there are so many tasks that are asked to be performed and charted by the providers in this guideline. 118 were counted by one of our members. And there isn't another area of medicine where the medical board lays out so many different things which are required. And I would encourage, as the guidelines are redeveloped, to really think more about how to make them extremely clear with bright red lines about things that should and should not be done, that make it much more clear to physicians about how they can stay out of trouble, because that this is a huge issue for doctors in practice. And it's unclear whether the monitoring and charting recommendations could be causes for discipline. And it seems like in reviewing some of the cases that are currently in progress that they can be, and that we think that may not, that these shoulds and these tasks and the recommendations may not really reflect the standard of care in the community as much as what the recommendations are, and we want to make sure that all recommendations are evidence-based. Controlled substance agreements, patient-provider agreements, and pain contracts have not been shown to prevent overdose, death, or the development of opioid use disorder. Those are clinical outcomes that are the clinical outcomes that are most significant, particularly in light of our opioid epidemic. There's also evidence that patients don't understand these treatment agreements and that they're perceived as unlikely to impact opioid misuse. The updated CDC guidelines do not recommend routine controlled substance agreements or patient-provider agreements, but rather recommend that patients and providers have a treatment plan that's clear. Routine urine toxicology may be helpful, but has not been shown to decrease overdose, death, or the development of new opioid use disorders. And we need to make sure that if they're recommendations, that they're recommendations and they're not mandatory mandates that could be used for discipline. Also, the use of pill counts is labor intensive, requires extensive training, is also not an evidence-based intervention, and it will not prevent clinical outcomes that concern us the most. Pill counts came from research when it was just a tool to see if people were actually being compliant. We also just want to make sure that whatever happens with these recommendations, that the verbiage becomes very clear for clinicians so that they can have a good chance of following them instead of just pushing back from patients in pain and not being willing to take care of them. Doctors go through their whole lives to have the privilege of practicing medicine, and things that can jeopardize that will affect their clinical judgment in a meaningful way. And I think these are factors to consider as you continue the incredibly hard work of updating these guidelines. I'll yield the rest of my time. Thank you.
Thank you for your public comment. Up next here we have Virginia. Virginia, you should be receiving that request on your end.
If you hear me.
Virginia, now we can hear you. Yeah, please go ahead.
Okay. I didn't know if I could hear you guys because it was muted again. So I'm not a chronic pain patient. I used to have chronic pain, so I don't have much to say on the high doses of medications. My concern, we have the guidelines, but we're not addressing underlying concerns, which would be more cutting edge. For example, prevention. A lot of this pain could be prevented in the first place, but like the one caller talked about all her medical errors and her diagnosis overshadowing, which Carrie asked her to conclude at that or ignore that, but it's a very important point that she was diagnosed overshadowed and not heard, which prolonged her care. So that really needs to be addressed because that happens very often. And that is in my notes sent to you. Also trauma and addiction and pain is also the root of it. Many times is trauma or trauma-informed or adverse childhood events. And the guideline mentions PTSD once. I sent a video from a pain doctor who asks the questions to his patients about pain and has like a team to address trauma. And he has a lot better outcomes than most doctors because a lot of times it's childhood events that are stuck in their nervous system causing a lot of pain. And I sent the video. Hopefully you guys will have time to watch it. And then again, somebody mentioned genetic metabolism. I also agree on this because a lot of times we can't metabolize the drugs. And there's a significant amount of people end up in the ER from medications that they're unable to metabolize. Either that or they need more drugs because they're a slow metabolizer of it. And a lot of that is covered by insurance. So I really think that should be part of it. Additionally, education. As you know, as said 100 times, it shouldn't take 100 doctors to figure out pelvic pain. It shouldn't take 25 doctors doing 50 pelvic exams to figure it out. There needs to be education regarding proper assessment and treatment of women's health, like pelvic pain, endometriosis, which I sent links to books for both of those, and etc. Because women are really suffering, they're getting overshadowed, and nothing's being done. If you have the guidelines but don't address the insufficient education and prevention and trauma, you're going to be in the same spot. So those are key foundations to what you're doing. and liposuction is causing a lot of harm. It's written every single time you send out a newsletter about doctors in trouble. Liposuction is often one of them, and that also needs to be addressed. And I appreciate all the doctors talking and all the patients talking, and I really appreciate you guys taking the effort to do this. I hope you really listen to what I say and address prevention, trauma, adverse events, genetic metabolism, and education. Thank you. I yield back my time.
Thank you, Virginia. Next up here we have Steven Steinberg. Give me a minute to send you that request, Steven. Oh, looks like you're not connected via audio, Steven. That's why I guess you were typing your questions there. If you do connect via audio, let me double check and see if it... There we go. Okay, Steven, you should be getting that prompt on your side now. Sorry about that. Go ahead, Steven. We can hear you.
Great. So, Dr. Gray, who was on this call, and I are the co-authors of the very large paper on the risks of opiates combined with sedative hypnotics, both benzodiazepines and non-benzodiazepine sedative hypnotics. I would disagree with the language on page 24. We know from our very large study, we're talking about 50,000 people easy, that the risk of overdose when benzodiazepines are combined with opiates is about 30% higher. And the risk with non-benzodiazepine sedative hypnotics is about 20% higher, and it is an additive multiplicative effect. So the combination of opiates plus benzodiazepines plus non-benzodiazepine sedative hypnotics is 60% higher. Yet on page 24, you say physicians should use caution. I would make that language much stronger. This is unless you're willing to accept a 20 to 60% increased risk of overdose as a baseline. I would say, I'm not sure if caution is the right word, maybe strong caution, or, because of the increased risk of overdose. And really, you're not fully addressing the risk of non-benzodiazepine sedative hypnotics. You mentioned, quote, should consider whether the benefits outweigh the risks. We know that the risk of non-benzodiazepine sedative hypnotics is a good 20% increased risk of overdose. I would make that a stronger statement warning people of the risk of the combination of these medications. And the other issue that you don't address is what I call the polypharmacy. And we see where we are talking about patients with benzodiazepines and non-benzodiazepine sedative hypnotics, and frankly, sedating anticonvulsant medications such as gabapentin or pregabalin. I would change the wording on page 24 to really make it very clear that these are, I consider a 20 to 60% increased risk of overdose based on a large published study to be significant enough to increase the page 24 to be much stronger risk. Thank you. And I can answer any questions about our study, but I don't know if Dr. Gray is on the line either. Still. So basically, are you willing to accept a 20 to 60% increased risk of overdose?
Thank you very much for your public comment. Up next here we have Lee T. Snook. Should be receiving that prompt on your end. Oh, just disappeared. Okay, up next here we have Karin.
I hold an MSW, and I know that you started off by saying that you wanted to have, a lot of flexibility for the doctors, and the way the guidelines are currently written, it doesn't really offer opportunity for a lot of flexibility for the doctors. So I'm hoping that maybe something can be incorporated or they can be amended somehow so that doctors basically have full flexibility with their patients. Unfortunately, I've worked with a lot of pain patients when they've been abruptly cut off of their medication, they're suicidal, and it really should be acknowledged that we have two issues that are going on. We have people that are trying to get pain medication for their serious medical issues, and then we have a street drug problem. And for some reason, those issues are not being separated and talked about correctly. It's kind of being lumped all together. So when people are cut off of their medications, they get desperate and they have to get them another way. And there's a lot of medical PTSD going on when they're trying to get their medications. There's a lot of discrimination, there's a lot of profiling happening. And unfortunately, I think if your guidelines are published the way they're written, I'm going to have a lot more people that I have to try and counsel from trying to commit suicide. So, I think the addiction specialist who spoke was right on the money. Contracts don't work. All of this monitoring, it's civil liberties, civil rights, dignity and worth of person, all of these things are being violated. And these are, these are problems. And I'm not sure why, because somebody needs a certain medication, they're being demonized and villainized. And so I hope that, you'll take these things under advisement. Thank you for your time.
Thank you very much for your public comment. Next up, we're going back to Lee T-Snip. You should be receiving that prompt on your end.
Lee Snook, can you hear me?
We can. Please go ahead.
Thank you so much. Well, first of all, as one of the people that worked on the 2014 guidelines, I'd like to thank Dr. Thorpe and everyone associated with this project to try to update the treatment guidelines. A couple of things that have become evident during this presentation and the comments that have been made. The overarching responsibility of the board is protection of the public health, public safety, and that sort of thing. The doctors are trying to practice medicine, and I'm a clinician. So I'm board certified in multiple specialties: internal medicine, anesthesiology, addiction medicine, pain medicine. I'm a medical review officer. I do a bunch of things. And my passion is for clinical medicine. One size does not fit all. When I started doing pain medicine, over 30 years ago, I received a lot of the patients in my community that many of the other physicians had done everything they could to try to help those patients, but could not. So I was allowed flexibility 30 years ago to do what I needed to do, and that included polypharmacy. In my years of training at Madison General Hospital in Wisconsin, in a tertiary university hospital, we used polypharmacy on all end-stage palliative type patients, and any patient that had a chronic health condition, we used multiple medications. Now in pain medicine, we've innovated with a lot of interventional therapies and other adjunct therapies. The Health and Human Services Pain Management Best Practices Interagency Task Force report emphasized multidisciplinary care. Now, we all know, those of us that are out in practice land, that it's hard to get that. It's hard to get psychiatric care. It's hard to refer to an addictionologist. It's hard to do everything all the time. It's hard to do. So we do the best we can with what's available to us in our community, individualized with each patient that has individual health care insurance or lack of, and various limitations, geographic, monetary, and otherwise, that may cause a problem. So comorbid conditions were broken out in the 2014 guidelines because there was a need to make the board and regulatory agencies aware that certain populations of patients had special needs. I would submit that even though that spirit was carried forward in these guidelines, that there really is no need to separate populations, but there should be guidelines that allow flexibility in individual care. And deviation from one person's opinion should not mean that you have committed a gross or extreme deviation from the standard of care. This is the fundamental problem that's driving physicians away from practicing medicine right now for pain patients, because of the very real fear of prosecutorial overreach from the Department of Justice through the medical board. And that's unfortunate. I mean, I understand we're trying to seek a balance here to protect the public and provide high quality care, but we have to have the flexibility to deviate. from what maybe another expert's opinion. And particularly in my practice, we have a high incidence of comorbid conditions, including multiple different types of psychiatric conditions, PTSD, and substance use disorder, the spectrum of substance use disorders, each of which needs to be managed as best we can. One size does not fit all, and individualized care is a dynamic and is contextual. And I think the guidelines need to reflect that. Overall, this is an excellent document. It's hard to codify the ability to be flexible, but it needs to be, because these guidelines become ruling documents when there is a disciplinary action. And unfortunately, and the CDC agrees with this, I was there at the AMA House of Delegates when this was presented in 2015, and I was the sole person on my subcommittee to say this is going to result in some problems. Now, I will say that the AMA, and I'm a member of the a couple of task force we're looking at currently right now. The Bankart Task Force, tapering of opioids and evidence-based medicine for substance use disorder care in the context of chronic pain and comorbid conditions. I would just request that we keep that in mind when we're looking at this, that we have to have built-in flexibility in these guidelines for us to manage our patients and do it without the fear that's untoward. Thank you for allowing me to comment. I really appreciate all the effort you put into this. Thank you.
Thank you very much for your public comment. Up next here we have Tom. Tom, you should be receiving a question on your end. Looks like your line's opening up there, Tom.
Am I on now?
We can hear you. Please go ahead.
Yeah, I was just, I think all of these efforts that the medical board is making in revising the guidelines is very commendable, but all these comments have been made for years now, and I'm concerned that all these revisions, whatever improvements are made, are not going to be heeded, because all this same information has been given time and time again by all state and federal authorities. And no matter how much people talk and give their information, even the lead authors of the CDC guidelines of themselves have said, I mean, if there's been one clear mandate from all state and federal agencies, it's been don't force taper pain patients. And even the medical board and the California Department of Medical Health, Consumer Affairs, Department of Healthcare Services, they had that webinar after the closure of the LAGS clinic, and Dr. Philip Coffin was assigned to lead that webinar, and the webinar was produced in conjunction with the CDC. And he said that was one of the main things of the CDC guidelines was to not force taper pain patients. And another finding was that this very act of force tapering patients, according to David Kahn from the California Society of Addiction Medicine and Dr. Philip Coffin, they said the force tapering in pain patients is driving more people to the streets and to these drugs which are killing people. And these drugs which are the drug abuse deaths, the drug overdose deaths, seems to be the main impetus for this whole change in opioid policy in the state of California. And the hysteria and mania of that seems to override any input from the American Medical Association, all the federal healthcare agencies, HHS, CDC. There's violations of the law, violations of the Americans with Disabilities Act, Section 504, Rehabilitation Act, the Affordable Care Act has anti-discrimination provisions. Opioid prescribing has declined precipitously in California, and drug overdose deaths are skyrocketing. And in spite of all the input from all these agencies, nothing changes. And it seems like there's maybe institutional ways of working. Yes.
Do you have specific suggestions for how the draft guidelines can be improved?
Yeah, they must. I think the draft guidelines, the board needs to look outside the normal purview of what you would think that your mission would be as a medical board. You have to, I think you have to look at the influence of mass entertainment and news media, the outside influences like the organization PROP, who has huge influence on our state leaders, the policymakers, like the chair of the Assembly Health Committee is, I think, under the grips of the influence of PROP, and popular narratives have stated for decades in movies and TV, those kind of outside things which you might consider. Oh, and the history of the DEA and the Federal Bureau of Narcotics, those kind of things are acting as real barriers to care for patients. And if you don't consider those things, which I think are probably you would consider outside the purview of the Medical Board of California, if you don't consider those things, as has already been shown, nothing is going to change, no matter all these great efforts that you are making.
1 minute remain.
So I think that's basically what I want to say, is that you have to start thinking outside, much bigger, because nothing's going to change. All the stuff has been done before, and the policymakers don't change.
Thank you very much. Thank you for your public comment. In the interest of trying to get, we still have people raising their hands, so we're going to go ahead and start giving people 3 minutes, and I'll give you a warning at 2 minutes left. But please try to be concise with your comments so we can get everybody in here before the end of the meeting. Next up, we have Dorian Barnes. Dorian, you should be receiving that request on, or Doran, I'm sorry. You should be receiving that request on your end. Looks like your line's open. Are you there, Doran? Doran, if you have a secondary mute or something like that, you might have something else blocking. Okay, we'll go ahead and circle back to you if you'd like to try again. Next up here, we have Christina Hildebrand. Christina, you should be receiving that request on your end. Christina, looks like your line's open. There you go, Christina. Please go ahead.
My name is Christina Hildebrand from A Voice for Choice Advocacy. We educate and advocate for informed choice and transparency of what goes into your body. We don't specifically deal with, or our members, followers don't specifically deal with chronic pain, but I wanted to address in these guidelines, I agree with a number of comments that have been made that there is a lot of should and must in this, which means it is required. May means that you can do it or you can't do it. I think we actually went through, for a different purpose, the 9,000 plus doctors that have been disciplined by the California Medical Board. And we looked at what they had been disciplined for. And other than marijuana issues, which, the law has changed since then, opioid is the next largest group of physicians that have been disciplined in some way. And it's no wonder that doctors are not willing to treat patients who are on opioids, because every doctor is scared of getting disciplined, and being disciplined, even if it's for just not writing, their notes well enough. It's better to stay out of it than to take that risk. And I think, our request is that you read through these guidelines from that perspective. I understand that you need to protect the consumer, but are you really protecting the consumer when you are driving doctors away from pain management treatment, and you are doing these patients a disservice because of that? And I think it definitely is a balancing act. There are doctors who have overprescribed, or patients that have gone into multiple, doctors' offices wanting to get opioids. But look at it from the perspective of a doctor. How do you get these doctors to treat the patients that need treatment? Because California is losing doctors on this front. As I said, we look at it from the perspective. other perspectives, but it's the same deal. When you come down hard on doctors for doing something that's incorrect, doctors run away from it. They don't embrace it because they just don't want to be disciplined. So please read through the guidelines again from that perspective and working out how do you balance it and how do you encourage doctors to treat those patients that need this treatment. Thank you.
Thank you for your public comment. I'm going to try Dorn again here. Dorn, can unmute yourself there.
Can you hear me?
There we go. Please go ahead.
All right, switched over to the phone line. The computer wasn't cooperating. Thank you very much for the opportunity to make a few comments here, and thank you for having this session. My wife is an intractable pain patient, has been for almost 30 years, and the details of her story are different than some of the other stories that you've heard, but the impact is equally profound. And the fear behind the way that pain has been treated and managed, I can't emphasize enough how deep that fear goes. In fact, I was even a little reluctant even to speak here today because there's a part of, I think, all of us that support family members that if you're getting care, you just want to hunker down because it's on such thin ice, it feels like. I'm encouraged by my friend Kristen Ogden, who started the session today, and echo all of her comments. Related to the guidelines very specifically, there are a couple of areas that I would encourage you to take a deeper look at. One is having an even stronger description of these unique patients who deal with these intractable pain problems. Those are the patients who are the least likely to get care, who get sucked into this syndrome of fear that is so prevalent in this space. Being very descriptive about that, I think, is very important. The second area is the whole topic, and it's been touched on a number of times, but the morphine equivalent doses or the MME discussion. Again, the damage that's been caused by the guidelines that really weren't guidelines that were put forward that really became caps. Looking at that language very carefully again and how that gets conveyed to the providers is important. And I did note very specifically in that section on page 14 that it says that referral to an appropriate specialist should be considered when higher doses are contemplated. I think the underlying issue there is where are those specialists to make those referrals? And that gets to this deeper issue of how you roll these guidelines out to the community, not only the medical providers, but also the pharmacists. Again, that's another area where fear and these misguided guidelines have really created damage across the board. I thank you from the bottom of my heart, from my wife's heart, for looking at this, for working to create more balance. There are patients who need this kind of care that just can't get it. And so that's the end of my comments. And again, thank you for the opportunity.
Thank you so much. Next up, we have a call-in user with a 216536 number. The 216 is the area code. You should be able to press *6 on your phone there to unmute if you're getting that verbal prompt.
Yes. Hello. Yes.
We
hi,
can hear you. Please go ahead.
Yes. Hi. I want to thank everybody for being here today. I'm amazed at some of the comments that have been made. They were great. One thing as a patient, I was wondering what's going to be different than the laws that were in place before, because nobody stuck up for the patients. As a person who lost their care 3 times at no fault to my own, it is devastating to a patient to find out that you can't get your prescription filled because you came over 17 miles to the pharmacy. One thing I keep hearing over and over again from patients, if you're going to do these guidelines, they go to a 30-day fill. They go to the pharmacy doesn't have their medicine, okay? So you have a person that's going into withdrawal, okay? Years ago, there was protection. You could get a 2-week supply, emergency supply, that is so important, and there's patients that they're never going to get better, and you're worried about opioid use disorder for them. I mean, yeah, there should be like a subset of patients, or there has to be protection, the barriers to care, the access to care is so important that, without that, if you can't get your medicine, you can get the prescriptions. If you can't get the medicine, what good is the prescriptions, You know, I feel terrible for doctors, and they are leaving in droves. I've been told recently that I was born in the wrong time in history. Okay, and you know, how do you think I felt when I came home from my doctor's appointment? And one size does not fit all. Okay, you know, yeah, it'd be nice if everybody only took 50 milligrams a day, but it doesn't work. And it's horrible medicine. You know, I'm asking you to please set that aside. Dr. Mackey recently gave a talk about the intractable pain patients, and he said that he would ask the California Medical Board to do not put in the hard rule of the dosage in that the CDC put in their guidelines. You know, this is very important. You know, this job is going to be so monumental that you're going to do that. I'm going to be praying for each one of you, because there's so much at stake here. You know, but I would like you guys to remember the patients. You know, it's easy to say, oh, you know, everybody should only get this amount, but everybody is unique, and I would ask you to keep that in mind. And the last thing I would mention to you is that every time, like people that are on disability, every time another drug is thrown on their pile of prescriptions, that's more into the donut hole they fall. And it's like, oh my gosh, how am I going to make it through the month? You know, so I'm asking you to please keep that in mind. And I want to thank each and every one of you for what you're doing. Thank you.
Thank you for your public comment. And next up here we have DK Cunningham. DK, you should be receiving that prompt on your end.
This is Deborah Cunningham and her daughter Jessica. I'm the caretaker. She's the chronic patient. I'm going to speak very briefly, and then she's going to speak. We are at the beginning of the age of individualized medicine. The idea of the MMEs, which have caused this incredible abuse of the doctors, and has in fact driven an incredible number of patients. I don't know, I saw a report of the statistics, to suicide, and drives them to street drugs when they cannot get treated. Please, please look at the MME levels. They are arbitrary. They are arbitrary and a horror. There's lots of scientific evidence that opioids, beyond most other medications, the range of toleration is enormous. As somebody said, you know, they were in the hundreds of milligrams. This is an abuse of the patient-doctor relationship. And it also shows incredible contempt and distrust for your members who are, you know, practicing physicians and pharmacists in the community, you know, of your own community, that you don't think they can treat their patients. I'll let my daughter speak for a minute.
People talk a lot about the comorbidities that come with pain that you have to deal with, and medications you might need to take, and all this other stuff, but a lot of people don't seem to talk about when they force taper you off, or when they take away all your painkillers, you can get new comorbidities. You suddenly now
get to undertreated pain.
Yeah, now suddenly you're in so much pain, you have gut issues. You're in so much pain, you can't keep food down. You end up having malnutrition. You're in so much pain, you can't take care of yourself. Someone was on here saying that she barely gets able to bathe once a week.
You've been there.
I've been there. There are so many side effects, so many negatives to not having your pain adequately treated, not being
the MMEs.
So it's 90 MMEs is arbitrary. It's
absurd and it's inhumane.
There have been multiple studies, at least especially in other countries, showing that it really isn't a real thing. It's a measurement because they wanted a measurement so that they could put in limits. But it's not a legit measurement, and as many people here have said, we all have very different tolerations. We all have very different methylations. We do things, everybody does things differently. When I was getting adequate pain treatment, the amount of painkillers I was on at 115 pounds, and small female would probably take out a 300-pound freaking wrestler.
Who's opioid naive.
Who's opioid naive. Just because our body sizes are different, just because I've been in pain for 16 years, there's differences between all of us. And the MMEs and the way guidelines keep trying to use them to create these limits are really, as my mom said, inhumane. Thank you.
It would be very nice if the California
1
Medical
minute remaining.
Board became a leader in turning around this disaster that was created by the misinterpretation of the CDC guidelines. And I'd really like to encourage you to do that. California so often has been a leader across the country. What happens in California gets adopted other places. This is desperately needed. Unless somebody, of course, is just a bean counter and getting rid of the pain patients is a good thing to do financially for the state. I would like to see California show themselves as a leader in being humane in the treatment of pain patients and smart and scientifically based. Thank you.
Thank you for your public comment. Next up here, we have Heather Rachel Davids. You should be receiving that prompt on your end. You there, Heather?
Can you hear me?
We can. Please go ahead.
Great, thank you. My name is Rachel Davids. I'm actually pain management at Sutter Medical Group. I wanted to throw in my 2 cents regarding some previous comments about all the musts and shoulds. You know, most of us as physicians and providers want to follow the rules. That fear of being disciplined is indeed affecting our ability to give care. So in regard to the recommendations, my direct 2 cents or feedback would be to the best of everyone's ability, keep it very simple. If we could bring it down to 2 or 3 or 4 musts, and then be very, very clear about the rest as recommendations. Not only will it help the physicians and providers, but someone also mentioned that the pharmacists are being put in a very difficult position. And I don't know if it's direct, any comments or recommendations would affect that. That is also impeding our ability to provide care, because even when we choose to prescribe, they are often not being dispensed. Simple recommendations, making it easily digestible across discipline, I think will allow all of our abilities to implement more effectively. That's all I got. Thank you.
Thank you for your public comment. Next up here, we have Nicole Hendrickson. Nicole, you should be receiving a prompt on your device there to unmute your microphone. Try sending it one more time here, Nicole. Unfortunately, I'm not seeing Nicole opening her line. This time, Dr. Thorpe, I don't see any additional requests in queue.
Thank you, Sean. Well, I really have to say I appreciate the thoughtful comments that have been made today, and I really appreciate everyone taking the time to attend this stakeholder meeting. I know I'm just speaking on behalf of the subcommittee. Mr. Brooks and myself, Mr. Persifka may have some final comments he wants to make, but I will say that all of these comments about the musts and shoulds, the morphine equivalent dosing, the urine drug testing, the individualized care, the issues regarding that one treatment does not fit all and one morphine equivalent dose does not necessarily fit all. These are all things that, and the comment that about California leading the nation in trying to come up with an innovative and an appropriate way of addressing chronic opioid therapy. The subcommittee is certainly very very sensitive to that idea. And in addition, an idea that came to me, and obviously this is something we need to talk about, but perhaps we need to have a joint task force with with the Pharmacy Board of California. And once we kind of come up with a working document because there is a problem with the pharmacy dispensing issues as well, and they're under certain regulatory limits as well, to make it possible for patients to get medications in a seamless fashion like we had been able to do for some period of time before, and yet not put patients at risk for opioid overdose. This is our desire. And, it's a very complex and intricate process. And I just want to tell you, we are listening, and we appreciate all your comments, and we will do our best to try to provide a document that actually is functional and is helpful for patients and physicians and for the state of California, and providing a safe environment as well. So, Mr. Pacifica, do you have other closing comments?
Yes, I think Dr. Thorpe, you really have said it all there. I too want to thank everybody for their very thoughtful comments. The other thing that I would like to add is that the task force will be examining all the comments, will be examining the next steps, determining everything that we can do to improve the guidelines, to make it a very useful tool to enable physicians to treat patients, to make a real difference in terms of getting access. But the one thing that the task force has also spoken about is that once the guidelines are issued, that really is just the beginning. It's quite clear that the medical board needs to undertake significant outreach in terms of communicating to all relevant stakeholders, to physicians, to patient groups, that we want to see this area be one in which we can enable patients to get treatment. And so what I would like all the attendees to think about is what we can do to reach out to you, to your groups, to communicate that we're here to enable patients to be treated. So there's going to be a lot of work for us to do, and we'd like all the attendees to give some thought as to how we can communicate better to the wider group of stakeholders about what we have to do to bring real change to this area. So I think at that point, I think, Sean, we can call the meeting to a close.
Okay, thank you very much. All the written comments in the Q&A will be passed along to Letitia Robinson at mbc.ca.gov. The email address is on the last page of the agenda. Anyone who wasn't able to make a public comment or has additional comments to make, please look for that email address on the last page of the agenda. Again, letitia.robinson@mbc.ca.gov. Thank you very much and enjoy the rest of your day.